Thank you for still being with us. We will close the session inviting Dr. Fatmah Al-Zahmi from the Mediclinic Parkview Hospital as a department head and consultant in neurology. Also, Dr. Fatmah is an associate professor, College of Medicine, Mohammed bin Rashid University of Medicine and Health Sciences in Dubai, and she will present about Duchenne muscular dystrophy insights into patient diagnosis. So it'll be a record.
Today I will be speaking about Duchenne muscular dystrophy, insights into the diagnosis. This talk is sponsored by Jaffa. This talk does not promote any products or specific therapy. In this talk, we will talk about Duchenne muscular dystrophy in regards to the epidemiology, genetic etiology, clinical symptoms, as well as diagnostic algorithm. Duchenne muscular dystrophy is a rare disease. However, it is the most common cause of muscular dystrophy worldwide. The incidence is 1 in 3,000 to 1 in 6,000 live births. In the world, there is 250,000 of people affected by Duchenne muscular dystrophy. Without treatment, patients with Duchenne muscular dystrophy have a life expectancy of less than 30 years. Duchenne muscular dystrophy is caused by a mutation in the dystrophy gene. Duchenne muscular dystrophy is inherited as an X-linked recessive disease with variable genetic etiology. Duchenne muscular dystrophy primarily affects males. However, female carriers can also manifest disease. Approximately 1/3 of the cases are caused by spontaneous mutation, thus lacking the supportive family history. 8% of female carriers can show disease manifestation. As mentioned earlier, because it's an X-linked recessive disease, normally females would not manifest the disease and they'll only be carriers of the abnormal gene and would pass it on to their male children. However, as mentioned, 8% of females can show disease manifestation with either asymptomatic high CK or less commonly cardiac manifestations. This is a result of a non-random or skewed X inactivation leading to the expression of the mutated allele. Again, it's up to 8% of female carriers can express the disease, and this is not a small percentage. There are certain types of mutations that can prevent the creation of a full functional dystrophin protein, resulting in dystrophinopathies. 65% of the mutations are large deletions and 10% are duplications. That is, almost 75% of the cases are due to large deletions and duplications. Remember that large deletion duplications cannot be detected by whole exome sequencing, which uses next generation sequences. This is important when we talk about diagnostic methods. Small mutations result in 12% of the cases, and nonsense mutations leading to a stop codon up to 13%. This is important when you think about therapeutic options. Less than 1% of the cases will not be detected either by deletion mutation detection methods or next generation sequences, and these are deep intronic mutations. In such cases, you might need further RNA analysis. Many of you would recognize this graph. It is showing the dystrophin protein in association with the muscle membrane. The dystrophin protein is very important to the stability of the muscle membrane. It works as a shock absorber during muscle contraction. When you lose the dystrophin protein, this will result in repeated trauma, disassembly, and mechanical injury to the muscle, with creation of free radicals and eventually muscle degeneration and fatty replacement. This is a histological slide from a 9-year-old boy. This shows you the destruction of the normal muscle architecture and the replacement with fatty infiltrate. All the white that you see on this graph is fatty infiltration. It is not unique to the skeletal muscles. The same pathology would be present in the cardiac and respiratory muscles as well. This is another way of demonstrating the disruption of normal muscle architecture and replacement of fat. This is a thigh MRI of a boy affected by Duchenne muscular dystrophy. At the age of 5 years, you can see normal muscle structure, and as the child gets older, you can see increasing in the white signal. The hyperintensity signifies the amount of fatty infiltration, and by the age of 14, you can barely see any normal muscle. It is almost fully replaced by fat. As we mentioned earlier, this would affect the skeletal muscles, respiratory muscles, cardiac muscles, as well as muscles in the gastrointestinal tract. With the skeletal muscles, the early manifestations would be delayed motor milestones, for example, lack of head control, delayed walking, waddling gait, recurrent falls. As the child gets older, the parents will notice a waddling gait, a development of tiptoe walking. They would show the gower sign when they try to get up from floor. As they get older, they will develop exaggerated lumbar lordosis or even scoliosis due to the weakness of the paraspinal muscles. These children will typically be wheelchair bound by the age of 10 to 15 years. Later on, they will start losing functional use of their extremities. They will not be able to use their hands to feed themselves, for example. In regards to the pulmonary manifestations, late in the first decade of life, these children may manifest nocturnal hypoventilation. They might have recurrent infections due to their inability to clear their secretions. If you're watching them with pulmonary function test, you will see reduced pulmonary lung volumes. Eventually, they will need non-invasive ventilation, and they could also progress to needing invasive ventilation. As for cardiac manifestation, the first manifestation would be resistant tachycardia. You will also notice abnormalities in the electrocardiogram with abnormally wide QRS complex or maybe low voltage EKG. These children, after the first decade of life, will start showing signs of myocardial fibrosis. This may not be evident by a thoracic echocardiogram, and an MRI of the cardiac muscle would be a more sensitive test to detect these abnormalities. Left ventricular systolic function and cardiac arrhythmias eventually will develop. This slide shows the different disease manifestations at different ages. In the first decade of life, the main manifestations are due to motor weakness, starting with delayed motor milestones to tiptoe walking, recurrent falls, waddling of gait, presence of calf hypertrophy, and eventually these kids might need to use a wheelchair at least part-time. In the second decade of life, the muscle weakness will progress to the extent that they might use the wheelchair full-time and completely use independent mobility. It is also time where they would start having manifestations of respiratory muscle weakness, which could present as recurrent infections to start with. They would also have nocturnal hypoventilation and might need to use non-invasive ventilation at night. It is important to regularly monitor these patients with pulmonary function testing. Cardiac manifestations may not be as apparent. It is very important that we do regular surveillance for cardiac involvement with electrocardiogram as well as imaging of the cardiac muscle. Imaging is better to be done with cardiac MRI to detect early involvement of the cardiac muscles. Again, this slide shows us the natural history of the disease. This timeline of disease manifestation will probably change in the next 5 to 10 years after the use of effective therapies for Duchenne muscular dystrophy. As we said, muscle weakness can also affect the GI tract with swallowing difficulty. It is very important to be very vigilant about the risk of aspiration in these children. Most of them, by the end of the second decade or early 20s, will need PEG tube insertion. They are also at risk of bone fractures, either due to immobility or due to the long-term steroid use. These patients will develop scoliosis due to paraspinal muscle weakness, which would compromise the respiratory function even further. Some kids would benefit from having scoliosis corrective surgery. All of the above would lead to chronic pain, which is very important to address in these patients. Duchenne muscular dystrophy patients have a high prevalence of neurodevelopmental disorders. Up to 19% of patients would fit the criteria for intellectual disability. Learning disability of some sort is present in up to 44% of the patients. Almost 1/3 of the patients would have ADHD, attention deficit hyperactivity disorder. Almost 15% of the patients would be in the autistic spectrum disorder. 1/3 of the patients would suffer from anxiety and mood disorder. These are very significant and important problems to recognize and address with the patients and their caregiver, as they could be a very significant source of distress. It is our job to recognize and address these issues with their caregivers. This is almost like a recap to what we have already spoke about in the natural history of the disease. So what are the early signs and symptoms of Duchenne muscular dystrophy? Well, the kids could present with delayed motor milestones. If a child is not walking by 16 to 18 months, you must suspect a problem. If they have weak head control, if they have difficulty with walking, running, or climbing stairs, if they are not able to get up from the supine position without using the arm support, if they have speech delay, and last one might be you notice that their calves may look bigger than they should, especially in a child who is tiptoe walking or seems clumsy and falling a lot. This graph is demonstrating the goer sign, which I'm sure many of you are familiar with, but basically these children are using their arms to kind of climb over the legs. So they will go prone first, they will push the trunk with their arms and then kind of use the hands to climb. So over the shin, over the thigh, eventually get up. You see the exaggerated lumbar lordosis and the hyperextension of the knee. They need to lock the knees to overcome the quads weakness to avoid falling. Showing you the different signs. This might be difficult to demonstrate in children. However, if you ask them to forcibly close their eyes to the point they bury the eyelashes, they're not able to do that fully. The weak head control, the difficulty rising from a chair without using the arm support, the wobbling gait indicating weakness of the pelvic muscles or the hip muscles, the knee hyperextension to overcome the weakness of the quadriceps muscles so that they can have the knees locked to avoid falling, tiptoe walking. So now that you suspect a patient with Duchenne muscular dystrophy or you think about it, what are the steps you could do to reach the diagnosis? So how can we reach the diagnosis of Duchenne muscular dystrophy? To me, the most important step in reaching the diagnosis is actually to suspect the disorder. In our field, the neuromuscular field or the pediatric field, and I'm sure in every field, there is expansion in the knowledge. We have many disorders, there is explosion of genetic variants, new therapeutic options, and it is impossible to keep up with all of the up-to-date knowledge about these disorders. However, I try to remind myself, and when I teach the students, that always consider the disorders that have potential therapies. I always ask myself, what are the conditions that I have therapeutic options for, that if I miss, it will be detrimental for this patient. I may delay a very important therapy or miss the opportunity to treat. So just by suspecting Duchenne muscular dystrophy, this is the most important step, because after that, it is easy to find the information. How do I check? Where do I check? Where do I refer the patient to? So, suspect Duchenne muscular dystrophy if you have any of the following. If you have elevation in liver enzymes or transaminases, what is that? Do I have a liver damage, or is this just because of the muscle destruction? Then you check the CK and you find that the CK is in the thousands. If a patient has a family history of Duchenne muscular dystrophy, I would not actually wait for them to develop muscle weakness. I would check their CK, especially if the affected individual is the brother. If it's a distant family, then you could wait. If there is any signs of weakness, then definitely check the CK. If there is no family history, any boy, any child who is not walking by a year and a half, or is showing signs of proximal muscle weakness, scalp hypertrophy, tiptoe walking, simple test, check the CK. The CK would be elevated in the thousands. If the CK is not elevated, you can pretty sure say that this is not a dystrophinopathy. It could be a different form of inherited myopathies or other causes of weakness, but you can be sure that it is not a dystrophin related. And then you can move to the genetic testing. Again, the genetic testing, we will talk about in the next few slides, but it is also important to know where are your differences. Do I have a genetic counselor? Do I have a neurologist or neuromuscular specialist that I can refer to so that they can deal with these details of the genetic testing? Delay in diagnosis. Analysis from the MD StarNet data from the United States analyzed around 800 patients with Duchenne muscular dystrophy, and they found that there is at least 2.5-year delay between the first manifestation and to reach the diagnosis. Most kids were diagnosed at the age of 5 years. So what are the challenges in the diagnosis? Well, some of these kids are born normal and they will not show any signs of the disease until they're 3 to 5 years old. 1/3 of cases, we said, are new mutation and there is no family history of disease. Sometimes the parents may not recognize the motor delay or the speech delay. Other causes for delay in the diagnosis of DMD, we don't have any universal screening. There are signs that could be subtle, especially if you are in a general practice and you're not accustomed to seeing such patients. You probably will not think Duchenne muscular dystrophy. The fact that these kids could have neurodevelopmental delay could also confound the diagnosis and bias the physician to think something else. So how to improve the diagnosis? Well, having a newborn screening program will definitely help reaching the diagnosis early on, even before the patient develops manifestation of the disease. There are currently in the United States efforts by advocacy and government groups to implement a newborn screening program for Duchenne muscular dystrophy. Until then, until we reach there, also always think of the disease, always check the CK early on in any patients with suspected muscle weakness. This slide presents you with a diagnostic algorithm when you suspect a patient with Duchenne muscular dystrophy. It's pretty much a recap to what we have mentioned in the earlier slides. If you have anybody with unexplained high transaminases, if you have somebody with, especially a boy with delayed motor milestones, delayed speech, or cognitive delay, I would check with the CK. CK is elevated, and especially in the thousands, go for Duchenne muscular dystrophy. Now, if you have a family history of Duchenne muscular dystrophy, well, it depends. If it's a sibling, I would not wait for them to develop motor manifestation. I would screen them by checking the CK. If the CK is normal, you can, with high level of certainty, rule out dystrophinopathy as the cause of their disease manifestation. So the CK is high, go for the genetic testing. What is the genetic testing that I can do to diagnose Duchenne muscular dystrophy? As we said earlier, that 70-75% of the cases are caused by deletions and duplications, which can be diagnosed using the MLPA technique, the multiplex ligation dependent probe amplification. Please remember that whole exome uses next generation sequencing and it's not able to detect large deletions and duplications. You need the MLPA testing. So this will cover 70-75% of the cases. If this is negative, you can go, and you're still suspecting Duchenne, you can go for small mutations, which is diagnosed by next generation sequencing. And with these two being negative, you are ruling out 99% of the cases. You still have less than 1% that are caused by deep intronic mutations, and this might need RNA analysis. Again, you probably will need the help of a geneticist and a neuromuscular specialist in these cases. In my last slide, I'd like to emphasize on the importance of the multidisciplinary care approach in treating these patients. This is by the involvement of different specialties such as pulmonary, cardiology, and gastroenterology. It is also important to involve the allied healthcare services such as physiotherapy, speech therapy, and psychosocial support. I'd like to remind you not to forget about the caregivers for these patients, as they're also prone to significant burden and a caregiver burnout. And this is the end of my presentation. Thank you for listening.
This was a very comprehensive